his target, those of you who remember that. And he, thanks, had a past history of a heart attack many years ago, 20 years ago. And he had a family history of heart disease. He was a smoker, he drank some beer. He was and got evaluated. He had an echocardiogram done that showed that his left ventricular diastolic dimension is 67, normal, upper limit normal being 55. So he has a big, baggy heart. A very poor ventricular function as the ejection fraction was 10 to 15%. He was sent over from another hospital because they wanted to evaluate him for transplant. First question of the day.
Can I measurement LVIS is that relevant? Chairman, are you looking at that frequently?
Yeah. Yeah.
Should we just look at the EF, but should I be looking at that number as well?
Great question. All right, so why would that matter? In this case, I told you what his etiology was. He had a prior heart attack, and now he's come back with a heart that's remodeled and grown. But if you're a person that had new diagnosed heart failure, that you didn't have that history or didn't have any history, the diastolic dimension is an important measurement for thinking about what are the possible etiologies. So new diagnosed heart failure with a normal end dimension is likely to be this low EF. Because one of the teleologic reason why the heart is larger as the EF plummets, that's the only maintained stroke volume. So if it gets bigger with a lower EF, stroke volume is higher because your end diastolic volume is higher. So the fraction of that volume then can be in the normal range. So normal stroke volume being about 75 to 100 cc's because his heart was so big. So if he's there and he had an end-diastolic dimension of 50 and an EF of 40 to 45, motion abnormalities, we would have to be thinking about other etiologies for his heart failure, ischemic. So what would those be? They could be myocarditis, they could be substance abuse. Well, usually alcohol will make the heart dilate, cocaine isn't always. It could be the beginning of a restrictive cardiomyopathy. There's a dimension that's not up here that I always look at too, and that's wall thickness. So normal wall thickness of the left ventricle is less than 1 centimeter, 10 millimeters. And if you start to get 1.5 centimeter wall thickness with an end-diastolic dimension or a small one, then you start to think about infiltrative cardiomyopathies, which is one of the diagnoses we make too late, like amyloid heart disease, for example. So, question. And I like questions because then you get more out of it. If I just talk and blab and you kind of suffer through it, you get a good punch out of it, but that's about it. All right. Quick, all right, question. So what HA-ACC staging system of heart failure, what stage is this person? This is my audience assessment here.
Go back to the data, right?
So this heart failure is different than the NHA classification system of heart failure. The classification system has to do with symptoms. So his symptom at rest when he showed up in the hospital, he was NYHA class 4. The stage of heart failure is different. So anybody have a guess? Oops. How do you do that? Look at that. I do that with this. No, yeah. So I know how to do that on command. That's good. Anybody have a guess? Yeah, there's no wrong answer. Well, that's wrong, but it won't hurt you today. There's nothing for a wrong answer. See, I'm going to help you out. Stage A is stage A heart failure because I have a risk factor for heart failure, and that is my blood pressure is too high at times. So that risk for heart failure is stage A. It's not very useful. Primary care setting for prevention, it's useful because you're trying to address those stage A criteria. Stage E is someone who has structural heart disease but has never had symptoms of heart failure. So this guy can't be A or B, right? So he's got to be C or D. And E combination is advanced. it's severe. Thinking about advanced therapies. Whoever sent him to us as a referral thought he was stage D because he thought we didn't think about transplant. Mostly, you don't know yet whether he's stage C or D because I haven't told you yet, but he's not on optimal medical therapy. We haven't attempted it yet. So he's somewhere in the CZ range until we figure it out. So a little bit of question. So there's an outline of those A, B, C's, and D's, but basically he's with current symptoms or structural heart disease and needing to think about advanced therapies, which we'll get to if we get time. Sure. Okay. That's how it maps out against the NYHA classification system, right? So the symptomatic status of heart failure we'll talk about when someone already has symptoms at some point. Stage A and B, we only tend to talk about NYHA classes because they don't know yet they've had heart failure. So this slide kind of maps out the stages of heart failure and the treatments as we know evidence is, is available to guide us. That is, I have to give you an updated version of this. When I pulled this slide in, I realized it's 2013, which there's a couple of things that have changed since 2013 that aren't in this slide, and I'll get to those things in medical therapy. So how in terms of they're very comfortable taking care of heart failure patients with systolic heart failure, and you know the guidelines. Okay, we're going to go through them and try to walk through in this guy's case what happened to him. So this is our patient. Come back to our patient. So he was very fluid overloaded, and he got diuresed aggressively the way we talked about last time I was out here. For those of you who remember or were there. In a way that got him down to a new target weight that we defined for him by getting rid of all available fluid that was excess. It was complicated, meaning he didn't have hypotension, he didn't develop acute kidney injury, and he got down to a BMI of 30 when he was at a target weight. And in the hospital, his blood pressure was adequate to tolerate a low dose of ACE inhibitor, in addition to spironolactone and a beta blocker. We gave him some instructions, and we got him walking around the floor, and we let him get out of the hospital. At discharge. Everybody familiar with the indications for those medications so far? Surprises up there? Any reasons? Anybody puzzled over why he was on any of those medicines?
By how low doses he's on, and he came to you being considered transplant.
Yep. Okay. So why might that be the case? He's at the end of his hospital stay with us, the first hospital stay.
I wasn't paying attention, I guess, especially to what he was on before he came in to see us.
He was only on cigarette-based tobacco.
Pretty minimal diuretic to keep him moving that.
Oh, sure. Just on 4 daily of respite. That is surprising, isn't it? But yet he was diuretic naive when he came into the hospital. On nothing. Any other? Now the low doses of Cinepril and carvedilol, what might explain that?
He's not hypertensive, so you have him on lower doses. You don't want to make him hypertensive.
Initiating therapy, and we haven't really tried to be aggressive to up-titrate. Carvedilol in particular, if someone's got systolic heart failure like he has, and they're in the hospital for the first time, you send them home without a beta blocker, or you just try to introduce the lowest dose of beta blocker, and we do that. Any questions or surprises about those meds? Get that. Yeah. Here's the next question. So he's coming back to clinic. And what should we do? 4 choices. And the question most likely to improve his survival. Two is increase lisinopril every 2 to 4 weeks to reach 40 milligrams max daily. Okay. Sorry, I forget your first name. All right. Debbie. So Debbie says number 2, max out his lisinopril or ACE inhibitor. Who agrees with Debbie? Anybody agree? Anybody want a different answer? And the question is, which is most likely to improve his survival? So the correct answer is actually 3. And the reason for that we can get into. Actually, I'm sure I put this slide in there. Basically, there are 2 sets of trials that are the background for this, and there's probably about 8 trials with ACE inhibitors, and there's about 8 trials with beta blockers. In a slide deck, I can put up the evidence for that, but I find that to necessarily be the best way to learn. So, 8 trials with ACE inhibitors basically said, let's get people to ACE inhibitor doses. And they did have target doses, but they didn't worry about it too much. They had target blood pressures instead. With the beta blocker trials, there were stage doses, and the target was to get to max tolerated dose without blood pressure target. So here, ACE inhibitor, you go back and look at what dose people tolerated. If you get medium range doses of ACE inhibitor, you had as good a mortality as max tolerated dose. So the curve for dose benefit, increasing dose benefit, levels off pretty quickly with ACE inhibitors. For beta blockers, on the other hand, an incremental benefit from every time you go up on dose. So max dose of carvedilol, anybody? 25 BID unless you use over 30, in which case the max dose is 50 BID. So max dose of metoprolol, methotrexate being the one we prefer, is 200 a day. And bisoprolol is the 3rd beta blocker that's FDA approved heart failure. This guy, it would be in a day. So the beta blockers, you can't go all the way to max tolerated dose without waiting. And why is that? Go up on dose, wait a couple weeks. Go up on dose, wait a couple weeks. Go up on dose, wait a couple weeks. The acute beta blocker is to drop pressure. Good heart rate. Yeah. And what else? Is contractility. So when you give someone a beta blocker, initially beta blockers were taboo in heart failure until the 1990s, because when it first got tried, people just went aggressively into this and dove in and put people on beta blockers and changed their dose and quickly put people into worse heart failure. So when the trials got invented, they had to factor that in. So the trials were designed to say, start people at 3.25, and the trial was written, every 2 weeks you're coming back to clinic, and if you're doing okay, we're going to raise the dose by doubling it. So you go 3.125 BID to 6.25 BID to 12.5 BID to 25. So that would be 4 visits. You get people to max dose. And by waiting those 2 weeks each time, you give people a chance to adjust. And when people that successfully treated with beta blockers is not only do they tolerate the up titration, but their heart improves structurally with up titration, because we've blocked one of the pathways that causes progressive structural heart disease is the beta agonist pathway. So by blocking that, we're allowing the heart to recover and repair itself. So the biggest mistake we make as clinicians, and it was just rediscovered, if you will, in another article last week, is we get people to the max tolerated dose of beta blocker. We get them started, and then we say, oh, okay, therapeutic inertia takes over, and we just leave them that way. The stopping rules, what should be the stopping rules for blood pressure when you're giving people beta blockers? Should you pressure is 96 over? Symptomatic hypertension, that's exactly right. And that's the other big mistake people make, is we don't start her. Now what happens, I increased his beta blocker and we got him to 12.5, and he was starting to get more dizzy. What should I stop? Stick to 12.5, back up. Okay, one strategy, hold the dose, let him see if he can adjust. So, yeah, if you've already maxed out lisinopril, that's right, and you know that that's not that, then going down to 10 to 20, you can do that. What's the option? Yeah, great. Yeah, actually, that's the biggest reason why people don't tolerate the ACE inhibitor, is we've over-diuresed them. And what's another strategy? No one's brought up yet. Yeah, takes it with relation to food, right? Carvedilol is one of those meds that we say take with food, can slow the absorption down to prevent some of the vasodilatory effects from being too fast. There's one other thing, and you'll see it happen maybe when you send your patients to heart failure clinic, for example, and they come back on a different beta blocker. So toprolol is not a vasodilating beta blocker and has a much less profound effect on blood pressure. So a real common thing that we'll see us do is switch people to metoprolol from carvedilol because their blood pressure drops too much on carvedilol. But it is also true that carvedilol is less of a bradycardic beta blocker and has no selectivity for beta 1 over beta 2, whereas metoprolol is 2-to-1 selective for beta 1 and bisoprolol 10-to-1 selective for beta 1. So if you want to slow someone's heart rate down, these are the drugs of choice. But if the rate's going too slow, you can switch them back over to carvedilol. I think that there's a few other good tips in there, but I tend to think of them as equivalent. There is one trial that said that metoprolol is inferior to carvedilol, but it was designed wrong in my opinion. And so I would say ignore it and use the beta blocker that is appropriate for the patient depending upon their heart rate and blood pressure. And other diseases would be the beta blocker of choice for some known vasoreactive disease like Raynaud's. So what about carvedilol? Yeah, carvedilol has that alpha blocking effect, and so you'll often, I've seen some of our patients, we bring out Raynaud's, they'll come in on metoprolol saying, you know, my fingers are always cold and numb, and so you switch them over to carvedilol and now they're feeling better. Okay, covered beta blockers ad nauseum? Yeah.
So you talked about using beta blockers for remodeling basically. Is this so far out from his heart event?
Why bother, right?
Right.
Okay, this is a real patient. All right, so I'm going to step this time here. So we talked about, we gave him number 3, and we bumped up his lisinopril to 10 a day because that's in the range where he gets the most out of it. We never added digoxin, we'll come back to that, and didn't adjust any other medications. He's exercising, he went to cardiac rehab first, and he started exercising 4 miles down on his bike. He took the advice to heart, he quit smoking. I wish more people were like that. And he also gave up beer. Besides the fluid, he lost 20 pounds on his own, so now his BMI is in the normal range. And I'm on a cardiopulmonary stress test to say, you know, do you qualify for transplant? I'm not going to get into the details of it, but that's probably as good as me. 26 mils per kg per minute. Transplant criteria is less than 14. We start thinking about transplant. So that's a measurement of his. Now, what happened to his heart? It's not to normal, but he shrank a bit, and it's improved to 35%. And there are times where we really, you know, are sure that we have a good prognosis. One tool in the kit is to measure BNP because P does tell us something about late prognosis. And I wouldn't keep for all the time that his P came back to normal. We're not thinking that's going to happen, but it happens. And I don't think we can ever give up fully on the possibility that if you get the right meds in place and people do the right thing and they're compliant, that they get some benefit. It happened in 6 months, and so then we can start to debate what to do next in a second. There are times where we don't see that happen for years, and it's interesting to me. Either patients I've taken care of that too long with low, you know, EFs of 10 to 15%, and then 4 years in, you start, you find something to really look, and you realize their EF is bumped up. There's one taxi cab driver I took care of in Boston, and that was the case. The only explanation I could ever come up with is he was not very compliant with his meds until finally he clued into it. And habits, I mean, people that continue to drink are putting their heart at risk for not getting better because alcohol can progress myopathy, alcohol use, and abuse. Other questions about him?
And his exercising his heart more, it sounds like.
Yeah. So he's really following through on the guidance for exercise.
Thinking about sort of what factors led to his heart recovering much faster. I mean, he realized everything.
Yeah. He followed the advice.
Was it the meds? Was it the
Yep. Yeah, and, in randomized control trials, we know the meds do some of it. But how do you augment that? It's doing the other stuff that.
What do you tell your patients?
Do I tell my patients to eat? Well, I'm a fan of the Mediterranean diet for cardiovascular disease patients, and we debate this. It's not what we have in our guidelines. We have low sodium, and don't tend to restrict carbs as much as the Mediterranean diet. Whereas the Mediterranean diet is not a fat-restricted diet; it's a saturated fat-restricted diet. There's some really cool biology about that, Mary, that have to come talk about the medicine might be food, but that's what I tend to. What do we do in the Healing Hearts Guide? It's the AHA diet, basically. It's low sodium.
Yeah.
No. Yeah.
Yeah. And whole foods, whole unprocessed.
Yeah. There is a school of thought out there that if you go to whole food plant-based diet, you can reverse cardiovascular disease. That it's any stronger than Mediterranean diet if you follow it strictly. Question? Agree with that?
Probably different. It's different. I am on the whole food
Yeah.
diet.
Yeah. Yep. Yep. I don't know if we can put the head with a strict Mediterranean diet. And then, there's a lot of good. There's one trial for Mediterranean diet that gets pressed because they keep rediscovering they have to reanalyze it. The PrediMed diet study came back out again and got republished because they found an error in it. It was in the New England Journal about a month ago. I don't know if you guys want me to. I wasn't going to go through every trial that builds the evidence for these things because I think that cut will come more ground if I don't do that. But I was going to mention just there are some underutilized meds that I want to cover, and the two that are most underutilized are this one, digoxin. It still has a place in the armamentarium. It belongs in people's boxes if they have symptomatic heart failure with recurrent heart failure exacerbations. Its main effect is to reduce all-cause readmissions. This is just years old. This is a review of a trial that was done years ago using observational data, and people that were on digoxin were less likely to be readmitted. They have to monitor the level, and in the other slide deck there's some details about levels and mortality that I'll give to Andrea to make sure that it's up there. Any questions about digoxin? Spironolactone is also underutilized. We all worry about high potassium. Yep, and that's the whole rationale for why there's a company that came up with a way to waste potassium when you have high potassium. There's a drug out there for hypotension now and promote use of this. But the times I've had to hospitalize a patient for spironolactone-associated hyperkalemia is one in my career. And the number of patients that have tolerated it is safely, meaning you catch the hyperkalemia in a safe way and you don't have to do anything about it, is ginormous. So I think we utilize it because we worry about that, but there are patients that are higher at risk for it. What's the creatinine cutoff for clinical trials that use spironolactone and eplerenone is the other one? How much CKD can you tolerate before you add spironolactone? Which helps prevent progression of CKD, so it's
Like 30 or something.
GFR 30. Clinical trials didn't use GFR, but they used a creatinine cutoff of 2.5 for men, and I believe it was 2.0 for women. So CKD patients were in these trials. Neprilysin. Anybody know? So the thing that's not in the guidelines is the newest medication that's FDA approved for heart failure that receives the most attention on CNN. So it's advertised heavily on CNN. I don't know if it's on every channel, but have you guys seen the ad where the sun will come out tomorrow? And that is the drug that inhibits Yeah, so I'll tell you the biology. So Entresto, which has a combination of an angiotensin receptor blocker, which, by the way, I didn't get into, but angiotensin receptor blockers are roughly as good as ACE inhibitors. So you can substitute in for people that have a cough over to ARBs. So this company took niacin as an peptide that breaks down natriuretic peptides. Remember what serotype? Niseritide was? I guess it still is. It's a recombinant form of natriuretic peptide, and it was thought that if we give natriuretic peptides to people because it's a vasodilator, it improve outcomes in heart failure. And it turned out to not be very useful, but it's still out there. So that was that biology. So the way to approach that is to block niacin and prevent the breakdown of natriuretic peptides, bradykinin, and have more of them around, and maybe that would help people with heart failure. And they combined that, I'm going to skip over some of the background that was on that last slide, with valsartan, an angiotensin receptor blocker. They created Entresto, and they should have Entresto. So it blocks angiotensin receptors, and it augments our endogenous vasoactive peptides. So it's a vasodilator for two reasons. Why block vasoconstrictor. And I'm sorry for the way this projects, but as advertised on TV, is the largest heart failure trial with the most benefit in all history. That's completely true, but it made the FDA, I guess, was tried in people like this gentleman soon after he was hospitalized before he got to guideline-directed medical therapy, and it's tried against ACE inhibitor. In this trial, if you were tolerating ACE inhibitor as an outpatient and still symptomatic with heart failure, then you would meet criteria B in this trial. So those are the people that benefit from Entresto, which last time I talked to a patient about it, cost them about $350 a month after their copay. So it's an expensive drug, it isn't new, it's beneficial in the right context. Should I switch that patient to, he's on lisinopril, should I switch him to Entresto at this point? And he's got no more symptoms of heart failure, so he no longer meets the criteria to be on it. So they will tell you to think about Entresto in people that are on ACE inhibitors or ARBs and tolerating them that are symptomatic with systolic heart failure, and also max dose tolerated beta blocker. A flaw in this trial is that people didn't have to be on spironolactone, and only about half of them were on spironolactone. So you could say, well, maybe the benefit was in part because you're doing things that other drugs that are already FDA approved that are cheaper were doing. So, okay. So pause for a second. It's 5, and I want to cover ground that you guys want to cover. So talk about what you might think of referring to heart failure clinic. I got a little bit talk about biases in heart failure, a little talk about personalizing care in heart failure, and then and genetics a little bit. Or so this is a multiple choice.
Choose your own adventure, if you will.
Yeah, where would you like to go? What would be most beneficial to you? So essentially, we kind of wrapped up the medical therapy. Any questions about that? What's your favorite? Andrew, you get to pick because I'm.
Did anybody else feel like trying to divide it maybe winter first? Yeah.
So I'll do that.
Yeah.
Okay. You missed a little stuff there, but all right. There we go. All right. So this is a simple chart of when we think as heart failure team, when we think it's helpful. Nuances are in part to get, think about what they might tolerate from med therapy. Also for the second bullet point, to just assess the etiology, because I think there are times where we aren't quite sure the etiology and maybe some further workup is needed and or more invasive testing is needed. So that's category. And then if in your chronic heart failure patients, these are some of the things that we think about. And this relates to the Healing Hearts protocol that we came up with you guys that Dan was participating in forming, where you get multiple use of acute care facilities in a period of time, persistent symptoms despite your efforts, low pressure, so you know you're not having trouble getting to guideline medical therapy because you're worried about the blood pressure. You got other organ dysfunction like kidney disease that you're worried about. You might have, induced or caused. Again, in ability to tolerate using this as a loop diuretics, just a sign that things are progressing, and so that in a lot of these things are signs that things are progressing to the point where you might need to think about advanced heart failure, which we can talk about. We did go through cardiac cath, then signs of a low cardiac index, which means that things are progressing as well. So cardiac index being to body size, their cardiac output. Low saturation means that they're extracting more oxygen from their body, and that's just another sign of a low cardiac index. Whether they deserve an ICD or a ventricular pacemaker, or again, inotropes, which you can come back to. And then any is, of course, is a sign of progression of heart failure. They're so common that I would say it counts as, they always count as a sign of things getting worse. But if it's way AFib in a person with chronic heart failure, then I would tend to worry that things have gotten worse. A lot of, people with AFib and heart failure, it's chicken and egg, right? We don't always know which one came first. That's a simple summary of it. Why do people benefit when they get over to heart failure clinic? In part, it's because there's a collaborative team with a lot of people able to pick up the phone at a moment's notice when patients are not feeling well, and that relates to what I did with this. I did it.
Yeah, I think you just need to put the mouse in a quick bracket here.
Oh, I see. Oh, okay, there you go. All right. Yeah, just my heart failure clinic is, over and over again shows that those patients that do that do better stay out of the hospital more, just mostly because they have access to somebody that knows them and can answer questions. And it's the same reason why telehealth for home health patients improves outcomes as well. And so, this is just a diagram of all the ways in which things can cause heart failure, and that's one of the benefits of getting over to a heart failure clinic and or cardiology clinic as a starter, is think about whether we're missing ischemia, or we missing valve disease, we missed something in the history that might have been, a cause of heart failure in the past. One thing that we tend not to spend enough time on and attention on is the family history, and genetics does play a role in heart failure. For some people, it's Mendelian. Mom had dilated cardiomyopathy, I inherited it. And for some people, it's more subtle. And we can talk more about that if you want. So, in a nutshell, guideline referrals. Now we still get more time. Any questions about that? Area options, about genetics. Talk about a couple of the meds that we didn't talk about. Oh, yeah.
Your perspective on benefits, where types of patients are getting into this.
Yeah, good question, Mary. There's a couple. If I look at it from a medical point of view, it's often because we haven't pushed on therapy yet, to the point where they've had the best chance of enjoying stability. And so when we look at a patient that's stable, the thing we're trying to do is, what can we change? Sounds wrong, right? Well, no. Trying to look at, you're feeling great, and your blood pressure is normal, and your heart rate's okay. Let's make sure you're on guideline-directed medical therapy. I think what often happens is people inertia kicks in, and we say, okay, you're doing okay. 6 and P5 of carvedilol twice a day, and so let's just not rock the boat and let's leave you alone. Well, that didn't give them the chance to get full benefit of the medication. That's one reason. Second reason is missed either or they have misrepresented their target weight. So we've let people volume overloaded and not given them the benefit of being at the volume status that gave them normal filling pressures. And that's the data around that, including the most recent data driven by a device that was developed to monitor filling pressures in real time. The CMEs, which I didn't bring slides about, but it's a device that you can implant into the pulmonary artery. It's done now at Maine Med, and then a person with that device sleeps on a pillow. The pillow interacts with the device and gives an estimate of pulmonary artery pressure. It can use that in addition to weight or other things. It's often useful in people that aren't good at or can't weigh themselves daily. That's probably the biggest benefit, but there's a lot of about it because it did reduce readmissions. It is an expense. It's $10,000 to put one of those, $15,000 to put one in, and then it creates work, which is why we delayed getting into it because we needed the workforce to take care of it because this device gives daytime someone sleeps on the pillow, and then it goes up to a website, and then our nurses look at the data, and then we'll say, okay, Mr. So-and-so, we need his pressure. So what you do is after you put that device in, you correlate it with left ventricular end diastolic pressure and weight, and then you check a pressure that you want to keep people at, and then use that to trigger changes in diuretic doses. Related to that, same topic, is non-aggressive diuretics. So we're using diuretics aggressively enough, and there are reasons why we back off. We think, okay, the creatinine has gone up. Often creatinine goes up because people are fluid overloaded, and you get back down again by diuresing them because you've reached their renal congestion. So that would be another reason. And then non-adherence and non-compliance is diet and medications. Okay. Yep. Yeah.
And that was used when it came up here. It seemed like people were using it, but now it seems to be more.
Where did you train? Okay, so I'm the same in. I'm completely with you. I'm a torsemide, whatever. And I like to say when I'm on service in Maine Med, take the pledge. And so I talk to the APPs and the residents. Take the pledge. And then what's the pledge? If someone comes into the hospital volume overloaded on oral furosemide, they don't leave the hospital on oral furosemide because it failed them. So give them something else. So torsemide, the reasons we use it more than furosemide are, what do you say?
Mine said 80% bioavailability.
Yep, 80%. So give something IV, everybody gets it. And so furosemide IV, 100% bioavailable, but when you put furosemide in your mouth, it's 20-80%. And so that's a really poor gamble, right? So, and there are some things you can do to tweak it. What increases furosemide bioavailability when you put it in your mouth? It's the opposite of carvedilol. It's an empty stomach because it binds proteins and then doesn't get absorbed as well. So if you tell people to take it on an empty stomach, if it's failing them, sometimes it'll improve their ability. But it might also last longer. So the half-life of torsemide is more like the 10 hours versus the 2 to 3 hours of furosemide. So this is developed as a once-a-day drug, but we tend to prescribe it twice daily.
Is there any difference between them in terms of needing to get pee at night?
Well, if you can done during the day, you have less to do at night. So that is one. But so when I reach someone, yeah, I mean, if you're effectively diuresing them during the day, then they'll have less excess at night. So whichever one you're using, and people that tend to complain a lot about peeing at night, the key is get them more, actively diuresed during the day. So yes, sometimes do split dose where you do half of your morning doses at night dose and whatnot. I'm a fan of VI twice daily dosing, and we do that enough. You see a lot of people. Some people tolerate it, like this patient I presented, but there are a lot of people that need dosing because after your loop diuretic wears off, you go sodium avid state the rest of the time. Your heart and body recover. That's fun. Keep going with questions. Yeah. I would say it's really personal. Like you ask people how soon with the diuretic do they have to go to the bathroom, I get a lot of different answers. One for sure is it's good to ask them that question, because if they're not having to go to the bathroom in the first hour, it's not the right dose. It's not effective if they're still volume overloaded.
Yeah, I have patients that, are late six, in the morning, late six, and goes back to the bunch, and then it's okay the next day. And they do different drugs.
Yeah, so the first one, its half-life is 2 to 3 hours, and it got its name Lay-6 because it's supposed to last 6 hours. So that's appropriate for that pharmacology. Torsemide, half-life, have I ever asked anybody? I really haven't asked much about how long it makes them keep going, so I don't know if I have an answer. Yeah. One thing about nighttime urine so if people are having trouble tolerating loop diuretics, you make sure that you haven't ignored the possibility they could benefit from spironolactone, because it's a slower acting, it'll help them get to a volume status, and then they don't need as high doses of loops if they can tolerate it. And plus they get the potassium sparing part of that, so they can come off of some of their potassium.
So the dose you really use would be like 50 or, I mean, because you're saying you're only getting benefit up to a certain point with it, so.
Yeah, in the heart failure trials, I didn't cover it, but the starting dose for spironolactone and RALS, that big trial, was 25. And if you didn't tolerate it, you went down to 12.5. First thing we do with mild hyperkalemia is we back off to 12.5. We don't give up. So then what dose titrate to? They were given permission to go up to 50, and that was it. There are patients, the hypertensive heart disease patients, that will benefit from much higher doses. And so, spironolactone up to 200 a day is within the window of okay for those type of patients. Okay, what's the sorbite and hydralazine? How many of your patients are on it? I'm sorry? It's African Americans, right? So you guys know the AHF trial taught us that in addition to ACE inhibitors, hydryl nitrates are beneficial in that population. Better how to in those patients other than skin color, but right now that's the surrogate for genetics. People that are ACE or ARB intolerant, and you should always think about adding those in for systolic heart failure because they are still beneficial in those patients. This is an often forgotten thing. Oh, they can't tell the ACE, but nobody went back and put them on Ike and Mike. You can't have isodose without hydralazine. Ike and Mike. And you have to prescribe both. If you want to use that expensive drug, I can't remember, that put them together. Okay. What other cover? Are you guys med patients, VAD patients? No. No, VAD. Ventricular assist device. LVAD, do you guys have any VAD patients? Yeah. So at some point you may want to, if you get your first VAD patient in the intermed, you may want to have us back to talk about VADs and management and what are the issues that you should know about as a primary care physician. And we for everything, Richard?
I think so.
My 3 bullets.
The evaluation. So there are 2 there. They're mostly redundant. So the ones not labeled intermed, there are only 2 pieces that we'd like to fill out there. That not med section at the top and number 6. If there's something you'd like to say about number 6. So other than that, we do need an evaluation. That would be great.
I'll leave you one last thought. Really good discriminator, prognosis in heart failure. I did this study. I love this study. But leave the room, and it's probably the only thing you'll remember. Anybody know what MQ is? And it was important for women and men, but it was important for both. Mortality and people with high MQ survive longer than people with low MQ. And this is systolic heart failure. Anybody? May not measure it, but if you had high marital quality, so if you had a good, and what I take that to mean is that if you have a nice social support system, a good relationship in your life, you do better with heart failure, which is not unlike any other chronic disease. So. All right, thanks for your time and attention. You're welcome. Yeah. Hi. Everybody knows how to reach you for help. Yeah, absolutely. And also the other folks, I tried to do part-time for a little bit, and then Chris was on vacation, so I wanted to see him. I want another good doctor, getting an email, or
Maybe next year we can, bring one of them in. Thank you.
You're welcome.
Okay. I'd like to get.
I'll save those, you want to save them to the? Yeah, I want to save a copy. Oh, okay, great, perfect. And then so what was, follow them to the roll, what did I do? I had the mouse down, when I had the mouse down? What is that? I sent on the motto. Yeah, and bring up the bar.
It's a real super feature of WebEx, what does it?
Oh.
Thank you, Dad.
Are you working today?
Awesome. No, I apologize for the hassle of fire, but, no, I wanted to, catch it because, well, I had to meet my colleague and like, I'm sure your thoughts on,